Epidurals. Is there anything that people with HDS or HSD really need to be aware of in general from a research perspective?
They have to be aware that they might not work.
Yeah.
But also we have to think about local anaesthetic
Yeah.
not working. One of the horrendous things I've heard from people in my research is saying, when we've interviewed them, that no one has listened to them when they've said, I can still feel it. And as a midwife, that breaks my heart, because you'd hope that people would believe them, but they're thinking, well, no, you've had anaesthetic, therefore it works. And it doesn't always work. Our research has said is that people who have Ehlers-Danlos syndrome need more local anaesthetic. So up to the maximum protocol, they might need double what a typical person needs. And they need to be believed when they're saying, you can still feel it.
No, this is documented in dentistry too. Often
Sure.
people will not get numb when they're at the dentist. And I know that there's some research there. Again, I'm not an expert on that, but this is something which is very much known. And again, it's not asking for the moon, it's asking to be believed. Hey, I'm Hypermobile, and if you're listening to this, I'm guessing you might be too. Hi, my name is Alex, and I'm your Hypermobile host, and today we have on the incredible Dr. Sally Pezaro, midwife and professor, and I was about to say the academic midwife because that's your handle and how I got to know you through social media. Sally, I'm so excited to have you here.
Thank you very much for having me.
Tell me a little bit about you, because I know I gave you an introduction, but you're involved in quite a lot. You just got back from a research trip to New Zealand. Is that correct?
Yeah, so research is my thing. And yeah, I've been on a Churchill Fellowship in Australia and New Zealand, data collecting for my research, which is really exciting, especially because it's kind of in the field of inclusivity and diversity in the perinatal space.
I love that. On social media, you talk about so many things.
Yeah.
You talk about, research itself, I think, which is critical. You do a lot of content for students. And if I was a student having to write research papers again, I would absolutely be following you. And you talk about pregnancy. And we connected, I think, through the pregnancy guidelines. I can't remember how. I might have found you or you found me, but somehow we connected and you messaged me, and I've never been so excited to get a DM. So thank you again for being here today. To start with, actually, before we get into that, we should do a medical disclaimer. None of this is medical advice in any way, shape, or form. We are talking about research as per the pregnancy guidelines, which I'll introduce by their formal title in a minute. But if you're someone who is pregnant, thinking of becoming pregnant, or you just have questions about your personal situation, it is critical that you speak with your appropriately qualified medical doctors about what's relevant to you and how to make sure that you have the best, healthiest, and safest pregnancy possible. But on that note, we're going to talk about the guidelines. They have a long title. And as I told you, I tried to print out one page and my printer said, no, you will print out. It said you will print out all, I think it's 34 pages. You will print out all 34 pages.
I do a lot of writing, don't I?
It is a lot. No, you and your team have produced quite the incredible document here. But it is, although I call it the pregnancy guidelines, and I hope you don't mind if we call it that for today's episode, the formal title, in case you're trying to look it up, is Management of Childbearing with Hypermobile Ehlers-Danlos Syndrome and Hypermobility Spectrum Disorders, a scoping review and expert co-creation of evidence-based clinical guidelines. Can you tell me a little bit about what guidelines are? Like, just for someone who is, a non-expert, a patient, like, what are guidelines? What do they actually mean?
Well, clinicians often use guidelines when they're working because they come across things that they're not sure about, or they deal with situations in a regular manner that they think this is the way we do things. And some are well established, some are less established. But to be honest, every clinician is looking for the right way to do things, the most evidence-based way to do things. And sometimes the evidence is really, really clear and really, really strong, and sometimes it's not. But we want to be as evidence-based as we can as practitioners doing what we do. And so what these were designed to do were to give clinicians and people who are having babies or thinking about having babies with hypermobile Ehlers-Danlos syndrome a guide to think about what may or may not happen, what to potentially expect, and when things crop up, what we know about what's best to do at this point in time.
There's so much I think, uncertainty sometimes with pregnancy in general, but especially when it comes to being pregnant and having something like Hypermobile Ehlers-Danlos Syndrome or a hypermobility spectrum disorder. So having a document like this, I can say for me as a clinician has been helpful. Hopefully you know who I am if you're listening to this podcast, but I'm an osteopath. So I'm a musculoskeletal specialist, but sometimes patients will ask me, they'll say, Alex, I'm thinking of getting pregnant, or I am pregnant, but I feel like I'm not getting the right care. What can I do? And I literally just say, like, print these off, all 34 pages, and take them to your doctor and just go through step by step, because they're quite comprehensive, and they cover a few stages of pregnancy. Can you tell me, and I say pregnancy, I know it's more than that, but can you tell me about the stages that they actually discuss?
Yeah, so we tried to cover, we couldn't cover everything because it's so massive, but we tried to cover, you know, a little bit to think about before you get pregnant, what you might want to think about in terms of genetic counselling, etc. And then really we talk about the first trimester, the second trimester, giving birth, and then the perinatal period, so the postnatal period rather. And so thinking about that as a kind of timeline, but also we've got things in there about nutrition and physical exercise and things to how to look after yourself and care for yourself through pregnancy. And so it might be that you're looking at that, weighing up your own risks and how it relates to your pregnancy, or it could be that, like you say, you give it to your clinician and they're probably really grateful because they're like, I've never heard of this condition before. I mean, that's what I was like. You know, Dr. Gemma Pierce, who I work with on these some of these works, you know, she said, Sally, you're a midwife. If someone was pregnant with hypermobile Ehlers-Danlos syndrome, what would you do? And I said, I've no idea. I wouldn't have a clue. And I'm sure there's lots of other people out there that feel the same in their clinical judgment, being not able to have that kind of information on their fingertips. And they're not sure if they've met a hypermobile person. They probably have, but they're not aware of it.
We're everywhere.
Exactly. So they probably haven't been aware that maybe they've had someone who's had a really fast birth, for example, and it's only in retrospect they think actually that person might have been hypermobile and I just didn't know at the time. And so these guidelines are really to make everyone make the best decisions at the time with the best available evidence for the situation they might find themselves in.
No, absolutely. And I think the point you bring up about feeling almost the feeling of relief that healthcare providers feel when they get handed documents like this. I know that prior to these coming out, I think it was it 2024? Correct. Yeah,
I
April.
think so,
Yeah, published May 15th, 2024. But prior to that, you know, people would ask me and I'd say, I don't know. Like, I guess I see a lot of patients who are pregnant. They seem to have this kind of pattern. Maybe ask your doctor about these issues, but I don't know. And I can say it's been really game changing for me to have a way that I know I can safely, you know, tell my patient, hey, take these guidelines, talk to your medical doctor, you know, go from there. I know a lot of patients get anxious, I think, sometimes about being perceived as overbearing or being kind of like, you know, stepping outside their role as the patient. But I think it's really important, and I'm curious for your opinion on this, that good healthcare providers will be happy to receive these. Like, that is a green flag.
Definitely. And I'm really excited that these are midwife led, but you have to understand it wasn't just me that wrote these. I was working with a group of multidisciplinary professionals and people with lived experience in co-creating these guidelines. And all of them were saying about their own professions, how people in their own professions would really be grateful for these guidelines, even if they're kind of simplified down, or they only skim read them, or they go to the exact bit that they need to, you know, with your particular situation. They'd be grateful for them. There's no kind of shyness about this, you know. Everyone's just looking for an easy, you know, straightforward way to do the best they can.
Yeah, no, absolutely. Table 4. That is, if you're watching this or listening to this, if you don't want to read everything, I think you should read everything. But if you don't, table 4 is where the stuff that you probably want to see is going to be located. Going back to the experts who helped you create these, can you tell me a little bit about the type of professions that were involved in this? I know we have obviously midwives.
Well, I was the only midwife actually. But I was really excited that these were midwife-led because we're obviously thinking about the physiology of birth as we're doing this. So midwives are the kind of specialists in physiological labour and birth. And then we had obstetricians, obviously, who are the experts when things don't go as planned, which is really important. And then we had nutritionists because we were thinking about the holistic picture of getting yourself in the best possible health to reduce the risk of things going wrong in the first place. Geneticists we had because we wanted kind of that angle on things. Lived experience patients and physical therapists was really important. And a number of other people that, we just had a huge list of people weighing in. And when we didn't have people on the paper as co-authors, we consulted experts because we needed, for an anaesthetist, for example. So when we talk about that, we need to make sure that we're not only talking to an anaesthetist, but an anaesthetist that has specialities in hypermobile EDS.
Where do you find them?
Exactly. So the place we found them was the Ehlers-Danlos Society. So I'm part of the consortium of the Ehlers-Danlos Society, and that gives us access to people, the very few handful of people who are working in this space, specialising in this space, and because they're specialising, they're at the forefront of knowledge as we discover it, which is really important.
Oh, no, that's fantastic. Tell me, just because we have some listeners, I know from countries outside the UK, I'm familiar with midwifery, having been here for a decade plus in the role that they play, but can you explain a little bit? Because I know the UK system's a bit unique. Is that correct?
I think so, yeah. I mean, midwives across the world practice differently, have different kind of... I mean, the scope of practice is the scope of practice, but of course, in some countries, they're able to practice more freely than others. But basically, we're the lead perinatal practitioners, the specialists in physiological labour and birth and pregnancy. So if your pregnancy is low risk, you should be able to see a midwife from start to finish, and they should be able to deliver all of your care to you. It would only be if you needed specialist help from an obstetrician, or potentially during your pregnancy, especially if you're hypermobile, you'll be seeing osteopaths or physiotherapists through that pregnancy. But they would be the coordinators of care. So because they know what is physiologically typical, they know when it's atypical.
Yeah.
So then they identify, hang on a minute, this isn't quite as it should be. You need to see a cardiologist or a anaesthetist or whatever it is at that point. And we are independent practitioners, so we have that autonomy to do that in the UK, but that's not the same everywhere, as we know.
No, it seems to be a really great system in the UK, to be honest. I've encountered quite a few midwives, and it seems like a role that really does help people when it's the right patients in the right setup. So I'm a fan.
Thank you.
And also, I have to give a shout out. You wrote a book recently on midwifery. Can you share the title real quick, just in case any midwives are listening and might want to check it out?
Yeah, thank you. So I wrote a book which was called Surviving and Thriving in Midwifery, because I'm really passionate about our profession, and I'm passionate about us thriving and, leading guidelines and doing amazing things in research and academia and everything evidence-based, because we do much more than catch babies. So it's important to support each other through that.
Absolutely. So getting back to the guidelines, if someone is thinking about pregnancy, they're hypermobile, let's say it's someone who's undiagnosed, I think that's a good question. Should they be potentially, if it is a planned pregnancy that they're thinking of, looking to get that diagnosis sorted? Because I find sometimes people kind of will deprioritize things, and we actually spoke about this before getting on the show. I recently got my diagnosis of hEDS, partly because I'm thinking of potentially having a child in my future, and I knew that I didn't want to go into a pregnancy situation without that label to help inform my care. So I guess my question is for you, how important do you think the diagnosis is to be able to know that the guidelines are relevant to you?
Well, as always, it's always a personal thing. That's totally what everyone wants to do. But I do think as a clinician, we like categories and we like boxes, which I'm not sure is always helpful. But in this case, I think if you have a diagnosis, that clinician can say, well, okay, I don't know anything about that, but I can look it up. They can find these guidelines. They can... and even if it's hypermobility spectrum disorders, they know the care's the same, the management's the same. So I think in this case, it probably is helpful. But I also know how unbelievably difficult some people find it getting a diagnosis. And if you think you're hypermobile and you follow these guidelines, I don't think it's going to harm anybody in that sense. So
I think that's a really great point. And accessibility of healthcare, it's a privilege to be in a country where even getting a diagnosis is possible. And in some places it has to be done privately or whatnot. So I think it's entirely relevant, everything you're saying, in terms of just looking at the guidelines, even if you're not diagnosed, speaking with your medical team and making decisions from there. I know too, when it comes to clarity, clarity is really helpful in healthcare situations. So it certainly does help everyone. And I can say as a patient, I just know I always feel confident when I can hold up something now and be like, this applies to me. Don't argue with me on this. So I think for all the patients out there, it really does help. This is a question from my patient. So I did talk to my patients and I said, hey, I'm having this incredible person, this expert in midwifery and academia on my podcast. Do you have any questions for them? And so one of my patients wanted to know, what type of professionals should people be seeking out before conception? So should they be talking to their doctor? Should they be trying to have a consultation with an obstetrician gynecologist? Like, should there be any kind of pre-pregnancy healthcare consultations?
I mean, in an ideal world, you'd speak to the whole multidisciplinary team, wouldn't you, before you got pregnant?
Yeah.
I don't know how realistic that is in real life. Midwives are, our scope of practice is pre-pregnancy, so it could be us. But my concern is that some midwives, or many midwives, might put you in a high risk category. Potentially unnecessarily.
Yeah.
But they might think, because this is a condition that could affect pregnancy and increase risk, then I need to refer to an obstetrician. So it might be worth speaking to an obstetrician as well as a midwife to say, what care pathway should I look at? Because you never know until you get pregnant what's actually going to happen, unfortunately. But you might want to look at the care pathway you go down before you get pregnant, just to understand what that might look like. And also, people are intersectional. So we have to think you're not just hypermobile. You might have high blood pressure, anything other related to your body and how your body is going to respond to pregnancy. So you need to be looked at holistically by somebody who can understand you as a person.
I know, I love that answer. It's never just HEDS.
Exactly.
I don't know if I can say never, but it's I can't think of the last time I saw someone where it was like only HEDS or HSD. It's usually HEDS, HSD, and co-occurring conditions, or friends, as I like to call them. In terms of actually managing this in a real world setting, what I try to tell my patients is, next time you happen to see your, geneticist, cardiologist, or whatever, those routine appointments that sometimes people have, I'm like, if you're the type of person who is planning things really far in advance, it might not be bad to bring it up at that appointment just to get an opinion on it. So that's my tip that I like to share sometimes. You mentioned that sometimes pregnancies, get classified automatically as high risk if they're HEDS or HSD. We were actually talking about this again before the show, that although there are complications and all types of traumatic and, distressing things can sometimes happen in rare situations in pregnancy, there are good pregnancies and there are good HEDS, HSD pregnancies. Can you comment a bit more on that?
Yeah, absolutely. I mean, this has come through in our research that some people said, I felt better than I ever did when I was pregnant. And actually, it kind of alleviated a lot of my symptoms that I had as a hypermobile person beforehand. And perhaps that's because the blood volume increases. Perhaps it's because the hormones are doing something different. The mechanisms are unclear. But what's true is that what people tell us is that they have great birth experiences, great pregnancy experiences, and it was the best time of their lives. So that's something important to remember, which is why, when I see people being ultimately classified in a high risk setting, I think, well, hang on a minute, we don't know yet. And it's a bit of a wait and see.
No, and everyone's situation is so different when they become pregnant. You mentioned that intersection of other conditions, and I've spoken with a lot of friends and some colleagues and different medical doctors about this, and I'm like, is there a way to quantify risk? Because I don't like uncertainty. That I think that's why I get stressed at the idea of me ever being pregnant potentially, because I dislike uncertainty, and it is a box of it is just an uncertainty mishmash of uncertainties. And the reality is, like, you just don't know how it's going to play out until you're in that situation. My mom, again, not diagnosed, but she was one of those people who loved being pregnant, had the easiest births, had a great postpartum too, because people forget about postpartum. And there are some people who will have, a really straightforward pregnancy, but a more difficult postpartum. So it can affect people in different ways. But my dad had to rush out to get a vasectomy after my brother was born, because he knew my mom, she would have just kept having babies because she had such a good experience. In terms of the things that don't go well, though, sometimes, I do have sometimes, I get questions from people again about, is the rate of miscarriage higher if we look at that, or stillbirth, just in terms of the more serious kind of outcomes. Can you comment a little bit on that?
Well, again, the research isn't necessarily strong here, so we're
Yeah.
only going on the research that's been done so far, and there's new research coming out all the time. But what we know about miscarriage is that it's only a tiny, tiny bit more common in people with HSD and hypermobile Ehlers-Danlos syndrome, and but it is more common to have a recurrent miscarriage, so that's three or more with the same partner. That's more common, and we don't know why that is. But in the general population, if someone had three miscarriages in a row or more, then we'd be thinking something, that was a sign that something underlying was kind of going wrong anyway. So we need to kind of look at that a lot more in terms of research. It's one of the big areas of research I think that needs to be done next, and also stillbirth as well.
No, absolutely. It's something I think this is just my take from social media. I'm on there as well, and a lot of times I think because of how algorithms work, certain experiences get prioritized more or presented more visually. I know that for me, I try to take breaks sometimes from it because
Yeah.
I find it distressing.
Yeah.
Just
People love to tell a bad birth story as well. They love
yeah.
it.
Yeah. I think maybe it's like processing trauma or something, but
Yeah.
it would be hard. I know if I was pregnant, I think I would actually like go dark for a long time on social media. Just because again, it's important to hear these stories. It's important to bring awareness and attention to everyone's experiences, good and bad. But I think that algorithms do tend to prioritize things which
Yeah.
get the most views, and often that is these more negative experiences. Going back to kind of the start of the whole journey, you talk about pre-pregnancy, you talk about conception and intimacy, which I love. I did an episode in my first, I think it was my second season of the show, about intimacy, which was really, a topic which I found challenging to talk about a little bit, but it's important. And good healthcare providers care about their patients' health, and intimacy does make up a component of being a healthy human. Can you tell me a little bit more just about, in terms of conception? I know that the guidelines don't touch on IVF, although they touch on intimacy. Do you have any thoughts there? Has any research come out or future
Again,
things?
we hardly had any research out there, but it was people within the team saying,
Yeah.
this really needs to be spoken about and we need to touch on this. And also, it wasn't just the team, it was people with Ehlers-Danlos syndrome that were telling us, we need to cover this issue. And obviously, there were hundreds of issues that people wanted us to cover, and we couldn't cover everything. But yes, we did think this was really important. And there's actually a couple of people doing PhDs at the moment with vulvodynia
Oh,
and hypermobility
Yep.
and those kind of topics. So what I would say is we don't really know a lot at the moment, but it's coming because when you're in this space, you get to know about that exciting research that's coming out all over the world. So I think there's going to be some exciting stuff published on that soon.
I can't wait for it. It's like Christmas when you're a researcher, it's like Christmas every day of the year because you always have studies coming out that you can't wait to see.
It's nerdy, but it's exciting.
I love it. Vulvodynia, for anyone who's not familiar with that, I'm going to try and say what it is. If I get it wrong, you correct me, okay? It's pain in the vulva, so the outer part of the vagina. Did I get that right?
Yes.
Okay, close
And
enough.
it's pain during sex,
Yeah.
in particular, that you focus on.
And vaginismus would be the pain internally as well.
Yeah, and I think it's all kind of connected in terms of what people are researching at the time because they're recognizing that is a real issue. So where I focus on pregnancy, there's 10 more people focusing on that. So
Absolutely. No, pain during penetration is something which is certainly a concern for a lot of people.
Yeah.
In terms of going back to IVF, is there any guidance out there on it yet, or it hopefully will come in future?
Yeah, there's nothing I've seen. And to be honest, I think in IVF, people don't know much at all anyway. They don't know the they don't know the whys, the hows. Otherwise, everyone would have a successful pregnancy all the time. So I just think that's an area where there's just a lack of knowledge. It's just that, the magic of the human body.
No, absolutely. I think one thing I have to say too, and we were talking about this before, is when I was only a patient and I'd never worked as a healthcare provider, I thought that healthcare providers had this like certainty about everything and there were clear rights and clear wrongs all the time and stuff. And it is so complex. And the HEDS and HSD and connective tissue disorders adds a whole other layer of complexity on top of something that's already complex. So no, just going back to that, it's going to be a theme throughout this episode, I feel, unfortunately.
Yeah.
In terms of monitoring and care, so obviously someone who's pregnant in the UK, they're going to be getting certain types of standard care and standard appointments and checkups. Is there anything extra that people should really be expecting? If there's someone with HEDS or HSD, is there anything that they should be getting, and that's a real problem if they're not getting it in terms of extra attention or care?
The two major things I would think of were physiotherapy
Yeah.
throughout pregnancy, because when you first become pregnant, the hormones start ramping up, but they quickly, start to take over and do what they're going to do, and everyone's going to be affected in different ways. And if you are not in contact with a physio who can quickly help you adapt to that, whatever that is, with joint support or pelvic support, then you are going to get in trouble quite quickly. And the earlier you can get in with a physio, the more they can support you through the pregnancy and in the postpartum period with healing. So I think that's really important. I think potentially later in pregnancy, so this doesn't have to be done right at the start, but later in pregnancy, I think it's really important to have an anaesthetist review, so anaesthetic review. And I think that's because we know that anesthesia doesn't work with a lot of people with HEDS and hypermobility spectrum disorders. So I think anaesthetists should know that, but I can't be confident that they all do. But because we know that's the case, for many people, you need to discuss, okay, what's good? If I need anaesthetic, how are we going to work that out? And that might not be a cesarean section. That could be an episiotomy. It could be suturing postnatally. So all of those things needed to be discussed and planned out, I would say. They're the two major inputs, I would say, during pregnancy that are really important. And the third thing I would say is what most people do anyway, but planning the place of birth and planning where you should birth and how you should birth, and being open to change and being ready. Because what you want to do is you can't predict what's going to happen, but you want to reduce your risk or minimize your risk of the adverse happening, and also maximize your risk of being prepared for what could happen for the best possible outcomes. So they would be the three things I would say are really important.
Physiotherapy, anaesthetist, and then thinking of place of birth.
Correct.
I think, that all makes sense to me. I never thought of the importance of the anaesthetist discussion, or maybe asking for that if I was a patient, but certainly now that's something I would ask for and try to get potentially. In terms of the physiotherapy, and there are specialist physiotherapists and different types of manual therapists who work with pregnant patients. I can say, as someone in this field, that I think building muscle mass as much as possible prior to pregnancy.
Yeah.
So if you're even if going back to me, if I was 25, I would still, if I thought that maybe I'd want to be pregnant in future, building up that muscle mass is just something I'd try and get a head start on. The prehabilitation concept, I think, applies to pregnancy. It's a physical exertion. Giving birth is a physical exertion, and then having a baby is physically exerting. So absolutely getting on that as early as possible with the support as well. You mentioned braces and other things. Again, people need to start to realize there are options out there for support if if you're able to get the right support or to access it. Compression garments. I know those come up in the guide. Yeah. I'm wearing my compression leggings today.
Well done.
I know I did not wear them yesterday, and I suffered because I had clinic and then a podcast, but I said today I'm going to make sensible life decisions. Yeah. Compression garments, they're touched on in the guidelines. Any thoughts on those?
I mean, they can't hurt, right? Yeah. This is another thing, if you're not hypermobile, you can still follow these guidelines and it'll be okay. Because we're thinking about varicose veins. We're thinking about blood flow and keeping that pumping right up to the heart in an easy way. Yeah. We want to stay away from edema if we can. I mean, there's some pregnancy conditions that will give you edema no matter what, and they're an important sign and symptom of something going wrong. But if it's purely to do with your connective tissues and your body being able to pump blood around, this extra blood, remember you've got a 40% extra blood volume when you're pregnant, so that's why you've got the extra pressure. Then yes, compression garments from early on, whether you and make sure they're measured for you as well a lot of the time, because people don't get them measured and then you get all sorts of problems. So that would be really important, yes, as well.
Absolutely. I do tell patients, early on, this is not for pregnancy, but sometimes even just seeing how you feel about compression garments too can be, kind of dipping that little toe in the shallow end of the pool. So really compressive sports ones can sometimes be a good place to start, but for pregnancy, absolutely, talk to your doctor, or for life.
Physios as well can help with that too.
I love, the whole measuring, because
Yeah.
it's a specific thing. I don't offer that service, but there are specialist physiotherapists who will do that. So patients should be reaching out to them. I should reach out and get my own special ones one day. Something else that comes up in the guideline is that you recommend, or sorry, the guidelines, not you, the research shows that it may be beneficial for people to be assessed for POTS or different types of, orthostatic intolerance. I instantly thought of falls. Sometimes people do get lightheaded going from sitting to standing, and safety is critical for everyone, but especially if you're someone who's pregnant. Is that something kind of up there with the anesthetist consultation you'd recommend that people maybe speak with someone about, even if they've never had heart issues previously or haven't been assessed?
I mean, you could, but the problem is that one of the early symptoms of pregnancy is fainting.
Is it?
Yes.
Oh, I had no idea.
So, it's one of those things. You're like, is it a pregnancy symptom? Is it a POTS symptom? Is it an HEDS symptom? And it's one of those things that you're not really sure. So if you go to someone, I'm pregnant and I'm fainting, they'll just say, well, yeah, you're pregnant. Do you know what I mean? Yeah. So perhaps POTS isn't, it could be exacerbated by pregnancy. It could also be stabilised by pregnancy. Yep. I am yet to be convinced as to whether it is better to get things diagnosed during pregnancy or non-pregnant, because pregnancy can exacerbate and highlight a lot of things, which is really good in a lot of ways, because you can think, actually, I am hypermobile, or I've got POTS or anything. But also, okay, when the pregnancy is past, then are you still having those issues, or have they gone away with pregnancy? So, for example, I am not hypermobile. I'm very, in fact, the other way. I'm very non-bendy. But during my pregnancy, I was in a wheelchair because my pelvis was so shot and it couldn't hold. It was just too lax, and it was just in really pain. So I could have said, oh, I've got HEDS, but of course I didn't. Yeah. It was just the pregnancy, and now I'm absolutely fine. It actually took me a year for the hormones to leave my body, and this is what happened to a lot of people. It takes them so long for the hormones to leave the body that actually to get back to the new normal takes a while. So to diagnose something in pregnancy, I think there's positives and negatives to that. Yeah. And we just have to listen to the symptoms that come up and look at the picture holistically.
There's so many confounding variables. There's so much going on. Yeah. And it's interesting hearing about your pregnancy. I have to ask you, I know you're not hypermobile. What made you interested in working with, and dedicating your research on, to people who are hypermobile? Like what got you in this field?
Well, Dr. Gemma Pierce, as I said, she came up to me and she said, what would you do if you saw one of these people pregnant? And I just didn't have a clue. And then she said to me, I think there's a real problem here. People on social media are really talking about this being a point of exacerbation in their condition. And when I understood what the condition was, I said, well, yeah, of course. Like, if that's what's happening with your connective tissues, that's really going to mess with your pregnancy. Yeah. And I wonder how. So then we did the first literature review that was published in the British Journal of Midwifery. That was so popular, they made it open access because so many people were trying to get to it. But then we did a clinical update. We did some primary research. We spoke to people, did 2 kind of really big surveys to understand more about it, and they informed the guidelines as well. And then through all that work, I was invited to the Ehlers-Danlos Society's consortium, and quickly realised that we needed to do guidelines, and I said, right, come on guys, let's do this. And then because I just knew what people needed was some kind of pathway, some kind of torch to light the way. Even though we didn't know the exact way, they needed a bit of hand-holding, really. And Dr. Gemma Pierce, she runs hEDStogether.com. And through Heads Together, we co-created some decision-making tools as well that help people talk to their clinicians, talk to their partners, and think, how does this condition affect me and my pregnancy, and how can people better support me? And we did an iLearn module as well with the Royal College of Midwives. So it's only a mini module, but members of the Royal College of Midwives can access it and find out a bit more as well. And then Gemma Pierce has kind of grown Heads Together to add more and more studies and more bits of information for people, so it can be a real hub for people to empower themselves and their care. So it kind of grew, and then, as I was saying to you before this podcast, I get contacted almost weekly now, if not more, by people saying, hi, I've read your work, can you help me? And so I know there's more that still needs to be done beyond these guidelines, because there's nothing out there that people, they're calling for. So always more work to do.
So it just pulled you into this field-based initial curiosity.
Well, I like to feel like I'm making an impact. This is the thing.
You are.
And so some research you'll do and you think, well, nothing really happened from that. But with this research, the more I do, the more people I help. And the more people say, oh my gosh, that paper really helped me, or those guidelines really helped me, or and you can make lives better. I think that's why we do research, isn't it? Like to make people's lives better.
I think so, certainly.
So that's exciting for me.
No, that's brilliant. And Heads Together has lots of great resources.
Yes.
I love it. What is it official? Is it a charity? Is it a research group? Like, what is it officially?
I guess it's a research consortium.
Okay.
I don't know. I mean, we kind of describe ourselves as a collective, I guess.
Yeah.
And it grows because, of course, we get more PhD students, we get more researchers that we connect with, and we can put more and more resources on there.
Yeah, there are some fantastic articles on there too. There's one about collagen in particular. I was looking at the other day, and the diagrams that are laid out, yes, it's scientific, yes, it's accurate, but it strikes that balance, I think, of scientific but accessible. So I would encourage you, even if you're someone listening to this and you're not in the healthcare research field, check out Heads Together. There's a ton of good resources on there. Going back to pregnancy and just kind of the guidelines and how actionable they are. I remember when these first came out, and I printed them off, and I was talking with my partner, and I said, so if I'm ever pregnant, you're learning how to do a home birth, like 100%. I told him, and I think I actually messaged you at some point. I was like, what does one need for a home birth, just in case? Again, for me, I think personally, I'd probably want to make sure I was in a hospital, but my mother had precipitous labors, and we came very, very fast, like 2 hours and 4 hours. And I've had countless patients who tell me, there was one the other day who was like, yeah, I was born in a parking lot because my mom couldn't get to the hospital. Tell me a little bit about precipitous labor. What is that? Am I using the right term? Is it precipitous labor, precipitous birth, or?
Yeah, I mean, what we tend to observe, this is actually the most exciting part of the research for me, because I think this is something we could research in future to learn more about. But what we tend to see is that people with hypermobility go into the labour and delivery suite, or whatever you want to call it, the birth suite, and they say, I'm in labour. And then they're assessed, and they say, oh, you're only in very early labour, very early labour. Go home, have a bath, have some paracetamol, which is, fair enough advice. And they go home, and then an hour later they're coming back and pushing in the car park.
That's what happened to my mom, was the whole, you're just going to be another 24 hours. It's your first baby.
Exactly.
Go away. Yeah.
Because we know that, as specialists in physiological birth, that, labour takes time. It's gradual. The body gets used to it. And, we listen to all those hormones doing their amazing things. But with hypermobile Ehlers-Danlos syndrome, it goes from 0 to 60, very, very quickly. Yeah. But we're not really prepared for that. And looking back over my career, I've obviously had lots of people who've, had born before arrival situations. And looking back, I think, were they hypermobile? In retrospect. Yeah. And when I was working clinically, I was a home birth midwife. So I was doing home births all the time. And home births are, great for people who want home births, but also they're great prep in case you have to have home birth, because there's no other option. So getting things ready and prepped, whether you've planned it or not, is a really sensible thing to do.
No, and I think it just helps you feel more in control of the situation. I know for me, when I've had health issues, the hardest thing is feeling out of control of my body, and just knowing things like, look, I'm pregnant. Yes, I have HEDS or whatever, but I know that I can reduce the risk of having a really problematic home birth by knowing what to do in advance and making sure my partner's prepared and I'm prepared. I think that's huge. I would also say I'd want stuff in the car as well. I'm a type of person who likes to prepare a lot. Okay. Real quick, just for listeners, if you don't mind me asking, home birth preparation stuff, again, just in case we have a BBA, a baby before arrival. What do people need? Is there a list on Heads Together, or is there are a few things you recommend?
There isn't actually a list on Heads Together.
We need a list.
It really depends. Yeah, we do. We need a list. It really depends on what area of the country you're in or the world you're in. Okay. Because where I was, we were fortunate enough to have a home birth team of midwives. So we would prep people for what they needed at home, and we'd meet them before, and we'd get to know their house and what's going on and how far they were if they away from the hospital, if they needed to transfer and all of that stuff. And that's a really good setup, because then even if you say, I still want a hospital birth, potentially you've got a community midwife 10 minutes away who can just get to you. So you're not birthing on your own or just you and your partner. Ideally, even if you were having a home birth, you would have a trained professional with you, because then they've got all the kit if things go wrong, and they can help you with the transfer if needed. And sometimes it's not appropriate to transfer either. Sometimes it's safer to stay at home.
Yeah, and things do happen. You can have a perfectly normal, uneventful everything, and then baby's coming, and things happen sometimes. So I'm very pro appropriate healthcare and support.
Yeah,
Absolutely.
and sometimes it's not a problem when babies come quickly because we just get our gloves on quicker. But sometimes it's a problem because obviously your uterus is then going, oh my gosh, that was a huge shock. And the baby's like, oh my gosh, that was a huge shock. I had, your uterus has no time to prep and get used to the idea of birthing really fast, nor does the baby. So then potentially you've got a uterus in shock, which doesn't contract properly after birth, or you've got a baby in shock that you've got to deal with. And that might be where some of the increased bleeding risk comes in. Because we know with fast births, forget hypermobile Ehlers-Danlos syndrome for a while, we know that fast births, there's an increase of bleeding because the body's kind of gone, oh my gosh, I wasn't ready for that. And then kind of, panic. But with Ehlers-Danlos syndrome, that might be contributing to that higher risk factor. Bearing in mind, we are prepared to manage that at home, but of course it is best managed in a hospital. So that's something to think about as well.
No, absolutely. When you say increased bleeding, does that refer to stuff like postpartum hemorrhage?
Yeah.
Is that?
Yeah.
Yeah.
So that's the main one that flags up the red flashy lights and everyone goes, right, now we need to put you on a risk pathway.
Yeah.
Understandably so, but I also think it's contextual.
Is there an increased risk in the evidence of postpartum hemorrhage in people with HEDS or HSD? And again, I know sometimes the evidence is weak and it's okay if,
It's very weak, but
Okay.
it's pointing that way, yes. But we don't really know why. Like I say, one of the things we can point to is the connective tissue just doesn't behave the way that typical connective tissue behaves.
Yep.
And also this fast birth shenanigans that just means that uterus kind of is a bit naughty. I'm not going to say naughty because it's not misbehaving. It's just behaving how,
We have to think about these things sometimes. It's your whole, your livelihood, your research. It's like we find different ways, I think, to contextualize and explain things. And I loved the image of the shocked uterus, the shocked baby. I was picturing the shocked, like, non-pregnant parent over in the corner, potentially. There's a lot of things that happen very fast sometimes.
Yeah,
and
there is. Yeah.
And it's hard to adjust. It's hard for our bodies to adjust to these changes. Like
That's it.
We see the adjustment, for some patients with POTS from sitting to standing, having baby inside you to baby not inside you very quickly must be incredibly shocking.
Yeah, it's a shock to everybody. Yeah. And so it's how the body and the people react to that.
In terms of, if we look at the guidelines, one thing, so when I talk about precipitous labor, I talk about, sometimes, if you're someone who's hypermobile, you need to be aware of this. Check out the guidelines. That's one of the videos I've done on TikTok. I get a lot of people in the comments being like, my labor wasn't fast. It took forever. It stalled, or I was induced. Is there any evidence that a slower than normal labor is more common in people with HEDS or HSD?
So this has come up in the qualitative data that we've collected, so people's storytelling.
Yeah.
And what we tend to hear is that people will say, my labour went on for weeks and days and months or whatever. I don't think there was months, but definitely weeks. And I'm not saying that they are lying in any way. I 100% believe them. However, what I think might be happening is that actually the uterus is doing what we call being irritable. So you might be in pain, the uterus might be contracting, that might be going on for weeks, but you're not dilating. The cervix is not dilating. So technically it's not labour. It's your body niggling, if you like, and being irritable before that baby potentially still comes precipitously.
Yeah.
Very quickly, that's minus 3 hours, less than 3 hours. But when people tell me I was in labour for weeks, I think, I believe you were in pain for weeks. I believe you were contracting for weeks and all of these things, but you can't have been dilating because otherwise there'd be a baby.
Yeah.
So I think, again, that's the soft connective tissues in the body behaving atypically in people with HEDS, which means that people are just getting those week-long horrible, probably sleepless nights and everything else, and saying I was in labour for this amount of time. But active labour probably came a lot quicker.
Yeah, so it'll go slow for some people until it goes fast,
Exactly. So
potentially.
it's almost like the 0 to 60 comes after a very long marathon of
Yeah. The car's stalling.
Yes, basically, yeah.
When it comes to actually having those contractions happen, and again, I'm not a pregnancy expert, to be clear, okay? But how does the baby get down? You don't have just a few muscles contracting. It is a whole body experience. And I'm doing this with my hand because I learned somewhere that it like really...
Yeah, it rotates.
It comes from up high, and it's this rotational thing. Can you describe that a little bit, just for someone who doesn't really know how the baby gets from there being pushed down, I guess?
Yeah, so this is another kind of problem with Hypermobile Ehlers-Danlos Syndrome and Hypermobility Spectrum Disorders, in that when people are pregnant, there's a lot of laxicity in the uterus, which means the baby thinks it's in a washing machine.
Is that a good thing or a bad thing? Probably not.
Basically, gets on all these crazy positions. So you can, palpate the stomach, the uterus, and, feel the baby's heads are down here and the bum's up here. And then the next day, the head's down here and the bum's round here, and it's all gone different again. Whereas what we would expect to see is that the head stays down, and towards the end of the pregnancy, it's either facing to the right or the left, because it's twisted and turned into the space where it can then descend into the pelvis. But with people with hypermobile Ehlers-Danlos syndrome, their babies often don't get in that position until the very last second.
Really?
The very last minute, is what kind of people say. And also, we need a baby to have a very flexed head to come through the birth canal. Yeah, so that's like the chin to the chest. But what can happen is, if there's extra room and the muscles are kind of lax and the connective tissue has more give, then a baby might not have its head fully down, or it might be slightly diagonal or something else, which just makes it not optimal for getting out and the way it needs to, which is getting under that pelvic, twisting round, getting under that pelvic bone and out. And so that's another issue we have to think about. But the body is very clever, and it still does its thing. It just does it in a non-typical way when you have those connective tissues behaving differently.
Yeah, which is kind of characteristic, I think, for life with most people with HEDS or HSD. They will have been doing things in a non-characteristic way the whole time, so I'm not surprised that pregnancy...
But it surprises midwives as well, because midwives are like, what's going on here? And, unless you know what's going on with this condition, it will flummox you, and you'll think, well, this doesn't make sense.
Yeah.
Not what the textbooks say.
One day we will have textbooks. Thanks to your research and other researchers, we will have the textbooks that say things, hopefully.
I'll try.
In terms of baby getting down again, it's not just the uterus, right? We get contractions from other muscles involved. Or are there things people can do to try and just bulk up that muscle tone, I guess is what I'm asking. Is that possible, or is it purely a uterus contraction thing?
It's a uterus. The main thing is the uterine contraction. You've got muscles all around the pelvis that will need to stretch and grow and hold the baby in the right position. But I wouldn't say there's anything during pregnancy that you can do to affect that. It will be more about, like you say, preparing your body prior to pregnancy to make sure you're in the best condition you can be. And obviously some people are more mobile than others with this condition, and the thought of doing weight training or walking is just impossible for some people. So it's about doing what you can.
It's hard because you can't really train your uterus. I was trying I was trying to think, how can we prehab for this? Not really an option there. In terms of what was I going to say? C-section versus vaginal birth. This is the question people ask all the time. Does the research say anything clearly about this?
It says things about both, but it doesn't say things about which one. So obviously, globally, cesarean section rates are astronomically high. And physiological birth under regular circumstances would be physiologically optimal for most people, because they heal best from it and have the least adverse outcomes from it. But it's not right for everybody. That might be psychologically. People say, I just don't want to push a baby out my vagina, thank you very much. I'd rather have us out the sunroof. That's fine as well. In terms of making decisions relating to Ehlers-Danlos syndrome, I think we have to think about the possibility of additional tearing, perineal tearing. So there is a higher risk of complex tearing because, the connective tissues are not going to be doing what we expect them to do necessarily.
Yeah.
So there could be third or fourth degree tears and complex tears, which have long-term health outcomes for people, even if they're repaired very, very well. People could be dealing, we know they're dealing with things long-term post-birth when they've had complex tears, and they say, do you know what, I wish I'd have just had a cesarean section because I would have avoided this, even though they had a vaginal birth. And I can totally see that. You can't predict that you're going to have a third or a fourth degree tear. We just know that with connective tissues behaving differently, that is a real possibility. And then you've got long-term issues. But then with cesarean sections, you're having major abdominal surgery.
Yep. There's like 7 layers of tissue they have to cut through.
This is it. So, you have major abdominal surgery. It's not low risk. And there's other implications in terms of the microbiome that we have to think about as well. So I do think it's, unfortunately, I hate saying this, it's very personal and very individual. But they're the main things to think about.
I sometimes think about it, and again, sometimes this comes from me thinking about myself personally as well. As much as I am a healthcare provider, as an osteopath, I'm also a human with HEDS. With a vaginal birth, it's the best case scenario is usually, it's great. It does seem to be the best kind of outcome, but sometimes those very rare events, as you've mentioned, can and do happen. And then you do have people who say, I wish I'd had a C-section. With the C-section, it seems like the known risks are higher, but they're kind of factored into the account a little bit more. They're there, and we know it's going to be post-surgical infection or different things that happen, the microbiome issue, as you say, and so on. But they're kind of more, tangible. I guess you can anticipate them more.
It is, but also we get the additional problem of healing afterwards. So, for example, we know that when we close wounds, they open up again for some people with Hypermobile Ehlers-Danlos Syndrome. And we've had that with cesarean section cases where, everyone's been sewn up quite happily and then it's just opened up. So, again, we need to think about how are we suturing the wounds, both in cesarean section cases and with perineal trauma.
Yeah.
How are we suturing, and leaving things in? Don't have anything dissolvable there, because people with Ehlers-Danlos syndrome need that extra holding together time.
Yep, it's that slow wound healing.
Sure.
This is one of my favorite things in the guidelines. You talk about, I think you do reference specific types of stitching or things that patients can talk about their healthcare providers with. And this is the thing that gives me hope and that helps me feel a lot more, calm. And I think it helps people who read the guidelines maybe even feel more calm, is like there are so many practical things that you can, advocate for, ask for, that I think are pretty reasonable to have done. Yeah. It's not unreasonable to say, hey, can I be stitched differently because evidence-based research says I should be. I think that's well within the realm of reasonable things.
Yeah, I mean, none of these guidelines, none of the things there are asking for the moon.
No, absolutely not. In terms of epidurals and so on, that's something else that people get really, really stressed about. You mentioned having these conversations with the anesthetist. Is there anything that people with HDS or HSD really need to be aware of in general from a research perspective?
They have to be aware that they might not work.
Yeah.
And that's a discussion to have with the anaesthetist. Yeah. And they're the specialists in this area, and they should know that people with Ehlers-Danlos syndrome, it may not work for them. But also we have to think about, so going back to the perineal trauma, local anaesthetic not working. And one of the horrendous things I've heard from people in my research is saying, when we've interviewed them, that no one has listened to them when they've said, I can still feel it.
Yeah.
And as a midwife, that breaks my heart, because you'd hope that people would believe them, but they're thinking, well, no, you've had anaesthetic, therefore it works. And it doesn't always work. And what our research has said is that people who have Ehlers-Danlos syndrome need more local anaesthetic. So up to the maximum protocol, they might need double what a typical person needs. And they need to be believed when they're saying, you can still feel it.
No, this is documented in dentistry too. Often people will not get numb when they're at the dentist. And I know that there's some research there. Again, I'm not an expert on that, but this is something which is very much known. And again, it's not asking for the moon. It's asking to be believed. This is not a research-based question, but I'm going to ask you anyways. I hope you don't mind. But if patients are in that situation where they're not feeling listened to, or they're saying, I'm not numb, Is there anything you think they should know they can do, or ways they can try and advocate for themselves? For me, it would just be having people there. I know I love having someone with me at all medical appointments, including, potentially giving birth. But is there anything that you could say to help someone kind of alleviate that fear a bit of not being heard, I guess?
I think it's about conversations happening before.
Yeah.
Because if you meet someone that you've never met before and they know nothing about Ehlers-Danlos syndrome, that's going to happen. But if you can talk to your health providers and make up a plan, a care plan before you go in. So either via hEDStogether.com, our decision-making tool, and you can say, this is really important to me. It's all there in your notes for people to read. That's really useful. We're obviously trying to raise awareness through everything we do in the research. And also, clinicians should be just listening. I can't, it's in our basic training, really. I can't kind of emphasize that enough, that it's just really sad when I hear that kind of stuff going on.
Yeah, because I've heard about it too, and it's hard because it is something that does unfortunately still affect quite a few people. But hopefully we will see improvement thanks to more awareness in terms of research guidelines.
Yeah.
Now, I have to say the guidelines also discuss postpartum. Do you have any advice, or are there any points you'd like to kind of bring up from the guidelines specifically relating to the person who's given birth following that?
Well, you obviously talked about slow healing, so that's something to be aware of. And obviously, you think about the nutrition. You need fruits, fibers, all those things to help you heal in the best way possible. One of the main things people talked about was caring for their newborn, having the hormones still swimming about, and the hypermobility. So, for example, if you are feeding the baby yourself, breast or chest feeding, then you are going to be potentially in the same position for a long time. Yeah. And that is something that a lot of people can't cope with. Or their mobility is so poor, they can't care for their baby in the way they want to. So parenting becomes hard, bonding becomes hard, simple things that they should be doing, like changing a nappy or whatever, just become impossible. And then they feel like they're a burden on other people asking for help, calling the call bell and things like that in the hospital. And that's something just to be prepared for and talk to people about beforehand. Anticipate, I might not be able to stay in these positions for a long time, so can I get pillows in place? Can I get wedges so that it helps me to stay in the same place for as long as I need to feed this baby. And you're going to have to bring me water, you're going to have to bring me food, because I'm not going to be able to walk about, especially if you've had surgery on top of your hypermobility. This healing is going to be slow and you're going to need that help. So it's about getting that in place and prepping for that, I think, so that the bonding and the parental experience can be as uninterrupted as possible.
Yeah, because it's such a special time,
Sure.
And it's, I think, important to get to experience that. In terms of absolutely big body positioning and support and so on, I've seen the difference that makes to patients when they get that support. I know a lot of people do have issues with breast or chest feeding sometimes as well, because of irritation to the skin. People with HEDS often have quite delicate skin that gets irritated through repeated exposure. But going back to the guidelines, everything that is brought up in there, I know even feeding is discussed. It's so actionable. I'm going to say my takeaway message, which is if you have not read the guidelines, you need to read the guidelines. Please go find them. It will be linked below. And if you are someone who is pregnant, thinking of getting pregnant, or even if you've been pregnant, but you want to just feel validated about your experience, you will enjoy reading them. They're probably one of my favorite research papers out there, to be honest. Sally, is there anything that you'd like to leave our listeners with?
Yeah, so I just wanted to kind of leave with saying I'm going to try and set up the first pregnancy-related Hypermobile Ehlers-Danlos Syndrome clinic, a digital clinic that hopefully can help people around the world, because it does break my heart that at the minute I'm getting so many people contacting me to help them, and I want to help them in a better way. So, follow for more.
I'm so excited for this. I can't wait to see this happen, and it makes me very, proud to be here and be part of this community, and to know, researchers and academic professionals such as yourself who are really actually making the world a better place for people who are hypermobile. I think you asked me like how I keep the podcast going. It's through sheer hope and, the joy that we get through these little bits of progress that you're fighting so hard to make. So thank you so much for being here. Please be sure to follow Sally. She is the academic midwife in one place, and Instagram at Sally Pezaro elsewhere.
Yeah, that's right. Yeah.
Go find her. You'll see me reposting stuff, and you can find her that way. But anyways, thank you again for being with me here today, and I will see you next time.